So, hello everyone, welcome to another discussion-based podcast here from Podmedics. I'm with Dr. Ed Wallet,
Hello,
and we're going to discuss diuretic drugs today.
all about diuretics.
Indeed. So, a slightly different format for the podcast. We've got a mind map in front of us, and we're going to navigate it and discuss things as we go along.
Yep, so we're going to start, I believe, by having a look at some basic background that enables you to understand diuretics.
Indeed. So, first and foremost, what are diuretics? Well, diuretics are drugs that act on the kidney. They're the most common drug we prescribe that act on the kidney, and essentially they just increase the excretion of salt and water.
There are lots of different types of diuretics, and different drugs have different actions and are used for a number of different indications. They're also some of the most commonly prescribed drugs in clinical practice, so it's a good thing to get used to what they do now.
Certainly. So in this podcast, we're going to discuss all of the major classes of diuretics that you'll become familiar with in clinical practice, and we're going to highlight the individual drugs. We'll talk briefly about their pharmacology, some of their indications and the most common doses that you'll be using, and any adverse effects you should be aware of.
And we'll also be on the lookout for Stephen's erratic spelling mistakes.
Oh, what have I done?
No, it doesn't matter. Indications.
So briefly, let's go through some anatomy and physiology. So first, let's just do some gross anatomy. So Ed, why don't you talk us through this next picture?
So this is a beautiful image from Gray's Anatomy. Not much to say here, except that there are two kidneys. The right one sits slightly higher than the left. On top of each kidney, you have got an adrenal gland enclosed within this structure, the suprarenal capsule, as is labelled here. Note also that you have got one major structure going into the kidney, i.e. the renal artery, that's providing blood and nutrients, and you've got two structures coming out of each kidney. So you've got the renal vein draining blood, and you've also got a ureter which carries the urine down to the bladder.
So this is a cross section through a kidney in the coronal plane. And this is just, we're not going to go through this in any much detail, it's just to see that there is, the kidneys are basically the workhorse of the urinary system, and the renal pelvis that comes out below that is just pipes and tubing really. So it's the kidney that does all of the work. And if I just highlight a few things here to you, you can see the suprarenal gland or adrenal gland sat on top there. And there's a grey capsule, if you like, around the outside of the kidney, and that's the cortex. We'll see a bit more of that later when we go through nephrons. And then there's the pyramidal system that goes into the papilla, and that drains into the renal pelvis, and that's where urine is collected and then drains out through the ureter.
Cool. And this is the magic nephron. This is the functional unit of the kidney. You need to be aware of the basic physiology that goes on here. We're not going to go into this in great detail, just about as much as you need to know to understand what the drugs do and where they act. So as Stephen already said, you've got your cortex and medulla, and notice that the span of the nephron goes through both of these structures. So some of the nephron lies in the cortex and some of it lies in the medulla as well. So if we start on the far left, we've got a structure called the glomerulus. The glomerulus really is a ball of capillaries. You've got blood coming in through the afferent arteriole, and you've got blood going out through the efferent venule. And basically what happens in the glomerulus is you get filtration going on. So you get pressure across there, which causes filtration of large amounts of solute within the solute and solvent within the blood. And then through the tubular system, you get selective reabsorption of various elements that are filtered at the glomerulus. And the major ones you need to know about are the proximal tubule and the distal tubule. And then in between that, you've got this structure called the loop of Henle, which dives down into the medulla. And then finally, after the distal tubule, you've got the collecting ducts, which eventually all form together to form pyramids, which together form the ureter, or the beginning of the ureter at least.
And just a quick aside, we've called them proximal tubule and distal tubule, but some books you may see proximal convoluted tubule and distal convoluted tubule. They essentially mean the same thing, but proximal refers to its proximity to the glomerulus. So proximal is near to it and distal is far from it. And convoluted means that they are coiled up, but we've drawn them fairly straight here. So don't be scared by those terms. We'll just call them for ease proximal and distal tubules.
Yeah. Okay, and Stephen, what goes on?
It's my turn.
What goes on here?
Well, in this one, we're just going to highlight some of the ports that have on the epithelium that deal with sodium reabsorption and other electrolytes, just so that we can, when we take you through the diuretics, it's easier to understand. So on the left-hand side of the screen, you've got the glomerulus, and as Ed said, you get ultrafiltration that produces a filtrate, and in the proximal tubule, most things are reabsorbed. Then it goes down into the loop of Henle. It has a descending limb and an ascending limb. The ascending limb has a portion that's very thin and a portion that's very thick, and on the thick portion you have this sodium, potassium and chloride symporter that draws in those electrolytes, and some diuretics inhibit that and can cause loss of salt and water. We'll see that later. There's also another symporter, the sodium chloride symporter, in the early distal tubule, and there are another type of diuretics that inhibit that. And the distal tubule then goes into the collecting system, where lots of things go on here with antidiuretic, hormone and aquaporins, but we'll go through those later when we see some of the diuretics.
Cool. So let's now talk about some specific diuretic classes. I think what we're going to focus on are going to be the thiazides, loop diuretics, potassium-sparing diuretics, and then finally and very briefly the osmotic diuretics.
Indeed. So let's go into the thiazides. So as we said before, we're going to split this into three. We're going to talk about the pharmacology, then we're going to talk about the uses and the most common doses, and then we're going to talk about some adverse effects you should be aware of. So let's go into pharmacology first.
Okay, so once again we see our schematic of the nephron, and what we've done is shaded the area where the drug is acting. So with this class of drug, what we're getting is inhibition of sodium reabsorption at the early distal convoluted tubule. These drugs tend to act within 1 to 2 hours of oral administration and have a typical duration of action of between half a day and a day. If one were to place them on the spectrum of potency of diuretics, these would probably come in at the moderate sort of level.
They would. So some examples of where we're going to be using thiazide or thiazide-like diuretics are in hypertension, and this may be a lone agent or in combination with other diuretics. So benzoyflumetazide is a very common thiazide. It's used a lot in elderly, in primary care at a dose of 2.5 milligrams for hypertension, and is very effective. Thiazide-like diuretics include indapamide. The dosage is the same, so 2.5 milligrams, and it's thought that this causes less aggravation of the electrolytes and with diabetes. Thiazide should not be prescribed to people who